Hi, everybody. Thank you for joining us. We have a couple minutes, but I wanted to go ahead and let you all start popping in. As you know, if you will use the chat for me, the chat button, and click on it at the bottom and type in your name for me. That's how, thank you, Gordon's kicked us off. That's how APA knows that you are here. So you will sign in for me using the chat, and you will also sign out. And of course, I will remind you to sign out right at 1 o'clock. Again, this will be for 1 hour of Category A ethics credit for you guys today. No, wait.
No, not ethics,
This
but
is
category.
Yes, thank you. Thank you. I was double checking that. As soon as I said it, I thought, no, that's not right.
I did discuss ethics some, but
Yes, this is for 1 hour Category A credit for you guys. What I will do, again, you'll sign in using the chat for me. You will sign out right at 1 o'clock as well. Evaluations will pop into your inbox right at 1 o'clock if you will complete the evaluation for me. Also in the evaluation, if you'll make sure in the one box that says your name and the one box that says your email address, make sure you get those spelled correctly and make sure you get your email address in there correctly. Those two fields I export out, and I use those to do your certificates. We have a new program that we've been using for about a year, and it's just so much easier for me to be able to shoot them all to you at one time. So if your email address is misspelled, it may not come to you. So please keep that in mind for me. Let's see here. We're going to give it just another few seconds. Again, this is for 1 hour, Category A credit. Evaluations will be popping into your inbox right at 1 o'clock. Complete that for me. If you will do so no later than end of day, Monday, July 22nd, and I will send you CE certificates no later than the end of the day, Tuesday, July 23rd. Again, please make sure you get things spelled properly and have your correct email address in there so it does go to you. We will be stopping for questions about the halfway point. So if you have any, you can go ahead and type it into the chat, and I will go ahead and monitor that and kind of curate the questions so that we have them together. And of course, at the time when we do that as well, you are welcome to unmute if you have questions or need additional clarification. And then we hope to have a little bit of time at the end as well for questions. I'm going to go ahead and turn it over to Dr. Mark Worthen. He is also an NCPA member and has kindly agreed to do this for us. So I'm going to turn it over so he has plenty of time. So take it away.
Thank you so much, Karen. And I appreciate y'all coming to this presentation on it's an introduction to disability evaluations with veterans, also known as CNP exams, compensation and pension exams. So this is an introduction. Thank you for those of you who filled out the survey that Karen sent out, asking questions like, have you done these before? And are you a veteran? We have at least 2 military veterans in the room. Hats off to you. Respect and appreciate your service to our great nation. And there might be more than 2. About half the people filled out the survey. And about half of you, well, maybe about 40% of you have no experience at all based on the people who completed the survey. And 60% have some experience doing CNP exams. So I'm trying to tailor this presentation to meet in the middle, but it is more introductory. And at the same time, we'll have time for questions. If you have any questions afterwards that you'd like to ask me, any comments, suggestions, please contact me. My contact information is there. And Karen did send out the slides, so you'll have them, as well as a recommended, call it a recommended reading list, as some other resources in addition to reading. that you should have received as well. So disclaimers, I'm not affiliated with any commercial psychological product or service, and I'm gonna let you read most of that. I don't represent NCPA in any opinions I share with you, and I do share some opinions. And there's some information about my background, so you are aware of my potential cultural biases, blind spots. And if you notice any, please tell me. That's the nature of implicit biases, is we are not aware of them. I am not aware of them. And often the best way to become aware is to have someone else point them out. And, oh, wrong way. Some thank yous to Andy for asking me to do the presentation, to Karen for, as I put it here, her unflagging dedication to duty, which has, then we could say a lot more positive about how much Karen does for us. And some of the folks that have helped me grow as a man in younger years and to develop as a psychologist. As most of you will likely recognize, this is the Vietnam Veterans Memorial in Washington, D.C. And I always get emotional looking at this. I had friends whose fathers, their names are on the wall. Some of the generation right after Vietnam. I was born in 1960. And yeah, it's this is why we're here. This is why we do this. Because men and women who either volunteer or were drafted into our armed services risk their lives for the rest of us. And we live in a country with freedoms that many people in the world will never enjoy. And we would not have those freedoms if it were not for the men and women who put on the uniform and risk their lives, and some of them die, to protect the rest of us. And that's what this is about, is helping out veterans who have suffered injuries or diseases as either as a result of their military service, or more precisely, that were incurred as a result of military service. It does not have to be caused by military service. PTSD is the prototypical example of something that is caused by traumatic event or events that occurred while serving in our armed forces or uniform services like the U.S. Public Health Service. And we'll go into a little more detail on that. But this is why we're here. This is the most important thing to keep in mind, is that when you do these exams, you're serving veterans, even if your opinion or your conclusions are not favorable to the veteran's claim. You're still serving veterans and their families because you're conducting an objective and hopefully accurate evaluation of their claimed disability. I'm going to answer questions that you all asked first, because I've been to so many workshops where, and this is so understandable, but there's 5 or 10 minutes left and everyone has questions, and particularly when people took the time to submit questions in advance, I want to make sure you receive an answer from me. So I am going to see if I can, yeah, there we go. So one of the first questions I received is, what is the VA disability response when a veteran is diagnosed with other specified trauma and stressor-related disorder? The answer is that VBA, Veterans Benefits Administration, a component of the Department of Veterans Affairs, must adjudicate those claims in this standard way. Now, I could talk a lot about what that means. It's in the Code of Federal Regulations. The most important difference between this adjudicative framework and the framework that's used for a PTSD diagnosis is that the veteran must affirmatively show they experienced a traumatic stressor that led to the development of what some people would call subsyndromal post-traumatic stress. And it's a higher evidentiary burden on the veteran to be able to demonstrate that this traumatic event or events happened, and it meets criterion A or close to it, since it's the other specified. And yes, close. Transcript is good. So I'm so used to pressing. Let's go back to pressing this space bar. No. So this, with the adjudication for post-traumatic stress disorder, if that's the diagnosis, that comes under a different part of the Code of Federal Regulations. This is the so-called liberalizing standard that was introduced in 2010. And the big difference is that the bold text down at the bottom, the veteran's lay testimony alone may establish the occurrence of the claimed in-service stressor. Therefore, the veteran does not have to find reports from his or her unit demonstrating that there was a traumatic event, or in the case of military sexual trauma, they don't have to produce police reports. Although the MST aspect of this regulation is F5, not F3, similar concept though. So it's easier to become service connected for post-traumatic stress disorder than it is for any other mental disorder that can develop as a result of sexual trauma. It was a great question. There's been legislation to try to change that. I thought at one point there was a big bill passed back in 2020. I thought that had done it. Turned out no. There's Senators Kester and Murkowski, Democrat and Republican, have been introducing bills every session of Congress to try to make it so that people who suffer sexual trauma and develop mental disorders other than PTSD can become service connected. So far, it has not passed. Second question, do you know of recent data on what percent of MST, I would say MST related exams, military sexual trauma is not a diagnosis, it's a circumstance, result in disability compensation support to veterans? Does it differ from men versus women? Yes, an excellent study. But the leading group in the United States now doing research on CMP exams is at the Connecticut VA healthcare system. And their affiliated faculty at Yale and the University of Connecticut, the departments of psychiatry. Lots of great research coming from that group. And this is one of the studies. There's the citation. There's some information about the study from the abstract. Huge sample size, over 130,000. Here's the result, or the findings. MST-related PTSD claims versus combat-related PTSD claims. 27.6% of the MST claims are denied versus 18.2, twice, double the odds of being denied. Men versus women. These are military sexual trauma related claims. Men are more likely to be denied. Lots of reasons for that, probably. One of them is the stigma surrounding men who are sexually traumatized. I encourage you to read about that if you're not already aware. As much as I've worked with men who suffered from sexual trauma, I can still catch myself having pejorative judgments that trickle up from the unconscious. We're implicated with that as we grow up in this culture. Black versus white. Black veterans, in many different contexts, are more likely to be denied compared to, and white veterans are more likely to have their claims approved, even if they don't actually have the disorder. It's a false positive. Third question. Thank you for this nice question. I suspect you will provide a good overview. What's the best way to get hands-on, boots on the ground advice and guidance? If you haven't taken them in a while, or you have not taken all the required VA video training, almost 9 hours worth, is excellent. It's really well done. I have several critiques of the VA, and I try to praise them when praise is due. And I should say that overall, the VA does an excellent job. I'm proud to have worked at the VA. My father was a physician at the VA for many years. VA does a lot more good than it does mess up. And there's always room for improvement. And so when you hear me critique VA, that's where I'm coming from. That training is free, available online. It tells you how to access it in the handout. Then a consultation, peer consultation, join the CMP, the PsyD CMP exam listserv, information in that handout. There's a couple hundred members now, I think, or close to 200. and it's been in existence for going on almost 20 years, I think. Lots of really smart, experienced people on that listserv who can help answer questions. The last question was, can you provide an overview of what types of assessment the VA prefers, how to find the most up-to-date forms and documents, and recommendations for chart review and interviews? I'm not sure if I understood your question accurately, so please clarify when we have a break about halfway through, or put it into the chat. I will be covering evidence-based assessment, which should address some of your question. The required VA training, if you haven't taken it, will answer a lot of those questions. How to conduct chart reviews and interviews efficiently is a great question. It's hard because if you work for one of the MDE companies, medical disability examination companies, you will not have that much time. If you want to make a halfway decent income, you'll not have that much time. On the other hand, it's important to conduct as much as possible an evidence-based assessment. It's hard. This is definitely an area where getting consultation will help. And I apologize for my, I'm a little bit, not dyslexic, the wrong term, but numbers, directions. I'll get there. This is something from my website about our research studies, though, conducted. Karen, I'm getting a message on my screen that says my internet connection is unstable.
You froze yep, you did. You froze just a minute ago on us, but we've got you back now.
Okay. I'm connected via Ethernet to a really fast internet service provider, so hopefully it won't be a problem. So you can check this out on my website. These are 3 studies conducted by VA researchers, mostly the National Center for PTSD, that show that evidence-based assessment using standardized psychometric instruments, which includes semi-structured diagnostic interviews and assessments of functional impairment, leads to more reliable and valid results, or more dependable and accurate results. And here are some statistics from one study that found false positive rate of 17%, false negative rate of 13%. Both are important, but both happen more often than they should. So that's about 30% of exams are not accurate. And there are the citations. It's on this page. I'm going to give the URLs in the slide deck, but if you search for psychological insight for veterans law attorneys, you'll find this. I put in a few little visual breaks. The walls of text get to me when I'm a participant in a workshop, so I like to intersperse. This is a painting by one of my favorite artists, Vasily, and I stumble over his name, Kandinsky. And this is a Greek, an amphora from ancient Greece, 530 BCE, depicting some Greek warriors. And I'm showing you this because history of veterans benefits dates back in Western civilization to the time of the Greek city-state. There's a lot to know about history. You're going to get about 1%. George Washington persuaded decision makers during the Revolutionary War to provide pensions to privates and non-commissioned officers. First time that happened in Western countries. During the 19th century, it was a real hodgepodge, and a lot of the veterans' benefits that were promised to vested were not. The government didn't keep its promise until veterans protested. Eventually, veterans got more politically savvy, and by the time of the Civil War, post-Civil War period, 30 to 40% of the federal budget was going to veterans benefits. Currently, it's about 5%. We got more sophisticated in the first part of the 20th century, and the modern era began with these 2 bills that were passed in 1917 and 19. A lot of this comes from this article by the leading veterans law scholar in the United States, James Ridgway. Highly recommend anything he writes about veterans law. And you'll see this is the bill from 1919. You will see this language still today. And when you look up laws and regulations, for example, no compensation shall be paid if the injury or disease has been caused by his own willful misconduct. That's still true today. And veterans are presumed to be in sound condition when they enroll. They pass through MAPS, the medical evaluation prior to being accepted. Then they're presumed to be in sound condition. There's some exceptions to that. That's the basic principle of that. The Congress at this time, wisely, I think, decided to provide benefits to veterans based on loss of average income ability, as opposed to a pension, which is a defined benefit payment amount, for example. And that but this is based on the average impairment that men at that time, men would experience as a result of an injury or illness. For mental disorders, post World War II, they developed a general rating formula for mental disorders. The way they did it is they list a constellation, a group of symptoms that are representative of various levels of impairment. At the 100% level, which theoretically means that a veteran's injuries or illnesses are such that they're not capable of earning any income. These are the symptoms that are associated with 100%. As you can see, reading these, they came up with these symptoms based primarily on schizophrenia. And most people with chronic schizophrenia, particularly in the 1940s, were not capable of working. So this makes sense. You have symptoms like these, 100% disability rating. What is important to know is that and here's the regulation, this is where it comes from. The Disability Benefits Questionnaire, the DBQ, is a reporting form. When you conduct a CMP exam, you write your report on this form. It asks very specific questions. One of the questions it asks is indicate if the veteran has any of these symptoms. It's a checklist. Actually, some of them are signs rather than symptoms. Nonetheless, you go down this list and check them off. What they don't tell you is that your answers to that symptom list item on the DBQ will, in most cases, is the deciding factor to determine the level of disability, the rating, the percentage most veterans call it. Because those symptoms, if you look at the symptom list, you will find that they are taken directly from the general rating formula. So if you endorse symptoms, 2 or 3 symptoms associated with the 70% level, the veteran most likely, if their VBA considers them to have a service-connected disorder, which is the VBA's call, they're the trier of fact, then they're probably going to get a 70% rating. The VA looks at other factors, not just the CMP exam, but the CMP exam is the most determinative. So understand what you're doing when you're checking off these symptoms. There's no guidelines, there's no instructions on when to endorse them or when not to. A couple of exceptions based on court cases, on case law. Be aware of that. Keep in mind that the Veterans Disability Program is an indemnity program, not an entitlement program. Indemnity is compensation for damage or loss. Think life insurance, disability insurance. An entitlement program is a government program that guarantees benefits. Think Social Security retirement. A lot of people are mistaken about this. Including veterans, think it's an entitlement program. Entitlement's a tricky word. Yes, they're entitled to these disability benefits, but it is not an entitlement program. These are a couple of United States Marines in Vietnam in 1968. Another visual break, but a little humor. I'll give you a little chance to read this. So I'm going to talk a little bit about screening for dissimulation, including significant exaggeration, feigning, malingering. And I found this to be quite humorous. NJP, veterans in the audience could explain it in more detail. Non-judicial punishment, it's punishment given by an officer without a hearing, without like a court martial. You have a hearing and you have legal representation. Socio-political context. It says continued because I took out some slides. It was too long. It's still too long. I'm trying to move through it though. Screening for possible exaggeration or feigning, and minimization is there's really no policy about, and people rarely screen using psychometric instruments for minimization, although it happens. So it's a good idea. The MMPI has scales and the PAI. Unfortunately, screening for exaggeration, feigning, malingering, which is the term I would encourage you not to use, is discouraged or prohibited or not paid for. The reality, both in the VA and probably even more so now that everything's been privatized, 90% of CMP exams are conducted in the private sector. The reality is that there's a lot of both positive and negative reinforcement to reach favorable conclusions that are favorable for the veteran's claim. That's something you need to be aware of. That's one of the disadvantages. You're going to encounter a lot of social pressure to, as put it crudely, give the veteran what he wants or she wants. And there's punishment if you don't. Now, I think I have a slide coming up here that says I'm being very blunt and direct in talking about some of these problems. They're much more complex. There's a lot of nuance that I don't have time to get into. And again, VA does much more that's good than not. So these are problems I'm pointing out that you need to be aware of if you're going to work in this area. I'm going to skip by this slide. Oh, there's my earnest plea. Want to keep in mind, I just talked about that. This is what the disability benefits questionnaire looks like. We're getting close to the halfway point, so I'm going to pause in a couple of minutes for questions. Keep in mind that this disability benefits questionnaire, that the particularly for initial exams or original claims, the first time a veteran's filed a claim for a mental disorder, including PTSD, you will be providing more than one expert witness opinion on the diagnostic, on the disability benefits questionnaire. You won't hear VA say that. You won't hear the MDE company, medical disability examination company, say that. The federal courts consider these to be expert witness opinions. You are an expert witness. When you give a diagnosis, it's based on your education, training, and experience. You're an expert. It's an expert witness opinion. Keep that in mind because over time, you'll hear psychologists saying, oh, it's just a snapshot of the veteran, how they're doing. You just ask them some questions, fill out the DBQ. What's the big deal? Don't listen to that Worthen guy. He's all pedantic on his high horse, talking about evidence-based, blah, blah, blah. It's just a little snapshot. It's just a little interview. That's not true. You're giving an expert witness opinion. The problem is that you will not be challenged. There's no cross-examination. There are no depositions. There are no written interrogatories, as there are in almost every other area of forensic psychology. If your opinion is favorable to the veteran, no one's going to complain. No one's going to ask you any questions. If your opinion is not favorable, you will be challenged. So keep that in mind. Doesn't mean you're going to get in trouble. It means you need to anticipate that. This is the symptom list I talked about a little while ago. And a little more humor. I'll give you a second to let that one sink in. And Karen, I'm going to pause now for questions.
Absolutely. So, Marianne, if you're out there, you are welcome to unmute. Marianne puts in a question. This was about 10 minutes ago. Marianne, oh, I see she unmuted. I'll let you do it, Marianne.
Oh, I can't even remember now. Hold on.
I see, no worries. Who determines the inaccuracies of the exams?
Oh, yes. Who does I found it. Who determines you mentioned something about inaccuracies in the exams, and if they're inaccurate,
Mhm.
who makes those determinations and what are they using to
Great
measure?
question, and good to see you, Mary Ann. Thank you for
You
asking
too,
that
dear.
question. So there's two answers to that question. One is research. So the studies I reviewed earlier, accuracy was determined by semi-structured diagnostic interviews and record reviews by psychologists or probably graduate students supervised by the psychologist, separate from the CMP exams, and often after a CMP exam. So that's the research answer to that question. In terms of who determines if a CMP exam is accurate, no one. If it's favorable to the veteran, you're rarely going to be questioned.
Right,
There's some quality review by the MDE companies. It's mainly, did you check all the boxes, of course? Are you using the proper language? And does it make sense? I mean, if you're writing gobbledygook, they're going to say, hey, you need to rewrite this. Otherwise, you will not be reviewed by psychologists for the most part. There are some of the MDE companies that have some peer review. It's limited. So now, if your opinion is not favorable, then you might be asked to reconsider your opinion, because the MDE companies and the VA get complaints from veterans if they have a CMP exam and they do not receive the benefits they think they deserve. And sometimes the veteran's right, the CMP exam
right,
is wrong.
right.
Sometimes
And
they're not. Go ahead.
and don't they, as you're talking about that, I'm thinking, with some of the active duty I'm seeing or have been in the past, they'll go back to an advocate at the
Mm-hmm.
VA, and then the
Mm-hmm.
advocate will help them find, there's a certain
Right.
time frame that they have to wait to
Right. So that's
reapply.
probably a veteran service officer. Veteran service
Mhm.
officers are either employed by the state, by one of the 50 states, or by one of the veteran service organizations, like the VFW, Wounded Warriors, etc. They veteran service officers provided a invaluable service to veterans. They help a lot. And of course, there's bad apples in every bunch, like any profession. By and large, though, they do a great job. Most of them are veterans themselves. They help veterans file claims, appeal claims at the lower levels of appeal, and educate veterans, help them decide what to file a claim for, gather evidence, or ask VA to get the evidence. So, and there are lots of different rules about filing claims, refiling, appealing.
Right.
Yeah,
Right.
there's a lot in there.
Right. And real quickly, when I also had asked, and I believe you and I had talked about this just outside of here, but one of my concerns has been the screening for mental health with a recruiter has been not thorough, and I don't know if that's due just because we're so low in numbers right now with the military, or but you're getting kids coming in at the age of 18, 19, 20s, where serious mental illness pops up in that age group. So
Right. The military has a tough job. The Army, Navy, and Air Force. The Marines are part of the Navy.
right.
So they, as you know, since you work with service members, it's hard to screen. They do try to screen for mental illness. One of my nephews is in the Marine Corps, and he had some problems. We got in trouble. He was, kind of like a mild juvenile delinquent, and he had a great recruiter who required him to show that he was serious. He had to come to workouts with a group of. It was kind of like a mini boot camp to show he was serious and could he hack it. And he had to get a job, and he had to get a haircut. He had to show up on time, and he had to be polite. He needed all these requirements so that this is a great recruiter. He wanted to know if this kid had what it takes to be a United States Marine, and my nephew proved it that he was, and Now he re-enlisted, and now he's I think he's a corporal now, which is impressive because I'm Marine Corps. Yes, but it's a problem. And once someone's accepted, as I mentioned earlier, they're considered to be in sound condition as of that point. Did anyone else have any questions?
Yeah, Susan McCammon asked a question. And Susan, you're welcome to unmute as well if you would like to. I see her looking. She can't unmute. I can ask the question, Susan, no worry. Oh, okay, I'll ask it. What are the symptoms and signs that have course law precedence?
Oh, great question. Suicidal ideation. So there was a federal circuit decision a few years ago that admonished the VA for, it was the Board of Veterans Appeals that made a decision and said that the veteran did not have suicidal ideation because he'd never been hospitalized. And the court said, whoa, 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 whoa. Where is that written? That it has to be hospitalization. They said that the examiner should determine, and I've got a whole page on my the PTSDexams.net website about this. The examiner should determine whether or not suicidal ideation causes functional impairment, because that's the basis of, as I mentioned in the beginning, it's an indemnity program based on the loss of ability to earn income. If the suicidal ideation causes functional impairment, which it can, as you all know, chronic suicidal ideation can cause a lot of problems. Even the person has no self-harm behaviors and has never attempted suicide, not planning suicide. Nonetheless, the chronic suicidal ideation is very disturbing for a lot of people, upsetting, occupies their mind way too much of the time, drains their energy, etc. You know what it can do. So if it's causing functional impairment, then yes, check it off in that box. And that's at the 70% rating level. So it's important to make that determination. Great question. That's the main one that there's case law about. There's some others that are decisions a little more indirect, but that one's very specific for that one item.
Thanks. We have another one. What symptoms of PTSD are more common or more pronounced in veterans versus civilians who have PTSD?
Yeah, great question. It depends on what the traumatic event or events are. So there are similarities. For example, military sexual trauma. There are a lot of similarities with civilians who've experienced sexual trauma. There are some differences in terms of, they're not huge differences in terms of how hard it is to report, how hard it is to get help from superiors or employers or law enforcement. There's been improvements over the years. It's still very frightening and discouraging for mainly women who are sexually assaulted and men. And so it's tough in terms of, there's a lot. It's a great question. There's a lot that could be said about that. There's a lot of good research on some of the characteristic symptom patterns. For example, the PAI, there's a characteristic profile that is associated with combat veterans. And there's also differences between between Vietnam, Persian Gulf War, and then OEF, OIF, Iraq and Afghanistan. So there's different types of traumas that mostly men, but also women experience during those wars. For example, IEDs were not as big a factor in previous wars. I hesitate to go in further because I think I'll get too much detail. It's a great question, though.
Let's take one more and then we'll come back towards the end. We'll let you finish. On slide 30, you mentioned screening for feigning. Exaggeration is discouraged, prohibited. By whom? Okay,
great question. Thank you. I should have said. So at the VA, if you happen to work for the VA, it might be a medical center that discourages or prohibits it. Since most exams are conducted in the private sector via the MDE companies, the way it works now is that the MDE company will not pay for it and they will not give you time for it. So if you get paid per exam, and you'll have psychologists working in the same office or clinic who are doing 6, 8, 10 exams per day, is mind-boggling to me. I'll restrain from saying more about that. And none of them are going to be screening for feigning or any kind of dissimulation. So you can do it, but if you want to give the MMPI-3, for example, or the PAI, you have to pay for the everything, and you have to it's going to take you longer to administer the test and score and get it scored, interpret it. So you are not going to be able to do as many exams as your colleague down the hall. You have to make a choice, and this is when I talk about the disadvantages and how to inoculate yourself against the pressure in the handout or in the flyer for this workshop. One of the best ways is to, if you're new at this, is to go in with a commitment to keeping to your ethical principles, the APA ethical principles, or if you're in a state where those are not incorporated into law, ethical principles are usually very similar. You're making a commitment to conduct ethical exams and do your best to conduct an efficient exam that is ethical and at least approximates an evidence-based exam. While I'm on the topic, I'll say, what are the most important aspects of an evidence-based exam in this being realistic? You have maybe 2 hours on average to do everything, reviewing all the records. That's number one, is thorough record review. It does take time. We used to have paper files that were 3 or 4 feet high, and there's the equivalent now of electronic records. Not all of them are that big. A lot of records to sift through, learn from your colleagues how to use search functions. If possible, a lot of them are images, so it's harder. But learn from your colleagues how to efficiently review the record. That's number one. Be prepared. That will also show the veteran respect. I hear all the time from veterans, and you can read about this on Reddit, subreddits, and Facebook groups. I went in, and that psychologist hadn't even read my record. And I could tell she knew nothing about it, or he knew nothing about it. So be prepared, thoroughly review the records, and then when you interview the veteran, establishing rapport is crucial. Veterans have had a lot of bad experiences with C&P exams and with the VA, although in general the VA provides as good or better healthcare than any other healthcare organization in the United States. Well, Vietnam veterans had a lot of bad experiences, and that was for real. But even today, vets have had some bad experiences, and there's a lot of worry that the VA's out against them. There's a lot of talk on internet forums how the VA's out to get, how to deny, to delay, deny until you die is one of the sayings you'll hear. I think a lot of that's lore, not reality. Nonetheless, veterans come in feeling guarded and worried that you're not going to believe them. And then, so communicating respect, measured empathy. By measured, I mean it's a forensic evaluation, so you don't want to mislead the veteran to thinking this is therapy, even if you tell them it's not therapy. If we're warm, empathic, friendly people usually, and if we come across that way, they can be misled into thinking you're there to help them. In a way, you are. Your first obligation, though, is to the truth. That's one of the differences between clinical and forensic assessment. As a clinician, you're an advocate for your patient. You're there for the patient. As a forensic evaluator, you're you're supposed to answer the referral question from the Veterans Benefits Administration, and you're serving the truth. Now, if you end up helping the veteran, great. And a lot of times you will end up helping the veteran. And you can also communicate respect and caring and give the veteran some time to tell their story. All of those things will lead to more openness in the veteran's part and a more accurate evaluation. I think another important critical ingredient of an evidence-based assessment is collateral interviews. If a veteran comes in and says, "Hey, will you talk with my wife?" say yes. One, it shows respect and decency. And number two, you will learn a lot talking with a veteran spouse or adult child or close friend. A lot of psychologists think that it's a waste of time. Oh, they're just going to tell me what the veteran told them to say. That's a very cynical view that I've found to be not true at all. The vast majority of the time, interviewing family members adds to the evaluation. That's one reason multi-method evaluations are more accurate in general, and gathering data from different sources is more accurate. Spouses will tell you things that the veteran does not tell you. Veterans that minimize, for example, the spouse will tell you, I have to get a broomstick and tap him to be able to wake him up, otherwise he'll punch me because of post-traumatic stress, hypervigilance. It could be in the middle of a nightmare. So talking to the spouse is another aspect of an evaluation. So where do you put your time and energy? Thorough record review, careful interviewing, learn some semi-structured diagnostic interviews if you don't know them already. If you can use them, use them. They're more reliable and valid than unstructured interviews. If you don't have time, learn them, because you'll start to incorporate some of those interviewing skills into your basically an unstructured interview. You can kind of make it more structured though. Include some of the ways that, for example, the CAPS, the clinician administered PTSD scale, the way they ask questions will help you elucidate and pull more information from the veteran that often helps their claim. It helps you reach a more accurate conclusion. And sometimes you'll end up hearing so many inconsistencies that you begin to think, I wonder if this is for real. So it can also help identify some exaggeration and feigning. Ideally, I've got some information a little later on the ideal evidence-based evaluation. So I suggest working your way down from that, choosing what you think are the most essential elements. I hope I answered your question. I think I may have gone a little bit beyond it, but feel free to ask or clarify later. Karen, I probably should go on.
Yeah, absolutely. And just a reminder to everybody as well, the slides just went out to you guys about 15, 20 minutes before the in the most recent email you have. So you do have all of Dr. Worthen's slides. Okay, go ahead.
And I can tell already, I've got 3 clocks in front of me, and it's already 12:45. So I'm not going to be able to finish this slide deck. So please feel free to contact me by email, and I'm happy to answer any questions you might have. Definitely join the listserv if you're not a member already. There are a lot of smart people on there who know a lot about these evaluations and have worked for the VA a long time, including some of the Yale researchers that do a lot of this great research. They're on the listserv, the psychologists. So these are some of the players involved. The basis of veterans' laws in these statutes. Remember that law consists of statute, regulations, and case law. There's a lot here. I'm going to try to just hit the most important things. This is when a veteran disagrees with a decision, they can appeal that decision. This is a little bit old. Ignore the part that says specified exams only. The private sector conducts most exams now. Otherwise, this is still accurate. This is the steps of appeal. The Supreme Court cases rarely get to the Supreme Court. Most cases don't get as high as the appeals court for the federal circuit, but a lot of cases do get to the Veterans Court, and even more to the Board of Veterans Appeals. This is another way to look at it. I did the other one. This one was done by a veterans law attorney. Another Kandinsky. This is a chart I have on my website, and it was in an article that Robert Moring and I did many years ago on CMP exams. There are a lot of important differences between your typical forensic psych evaluation and VA CMP exams that are important to know about. I'll let you read that. Again, feel free to ask me questions. I'll let you read that later. I'm going through it too fast to read it now. A great quote from the Veterans Court early when it started in 1989. I'll let you read that later, but really nicely written. It's okay to say when you give an opinion, you're going to hear people say you have to have the magic word, at least as likely as not. And that's true. You have to use language that clearly indicates whether it is more likely as not, or at least as likely as not, which is that equipoise, 50-50. In veterans law, if it's 50-50, the benefit of the doubt goes to the veteran. That's why that phrase is used, at least as likely as not. if in any forensic evaluation report or testimony, we should indicate our level of confidence or certainty. And it's no different in VA disability exams. I will often write, it is more likely than not, or it is near certainly likely that this veteran has post-traumatic stress disorder as a result of the traumatic incidents that she endured during her service in the U.S. Army. So feel free to express your level of confidence. It does not have to be at least as likely as not for every report. The VA uses the term medical opinion. Note that medical includes psychologists, audiologists, and then all the medical disciplines. The federal courts call it an expert witness opinion. I mentioned that earlier. The federal rules of evidence that govern most are in play for most forensic psychological evaluations. Even if you're in state court, they're usually very similar, like North Carolina rules of evidence. They're usually very similar to the federal rules of evidence. The VA does not follow the federal rules of evidence for when they adjudicate the claim. However, the federal courts have indicated the federal rules of evidence are good guide. So I would encourage you to read them and understand them and comport your evaluations and reports to those federal rules of evidence. Why not aim for the best? A little more humor again. Fabulous. I love cats. What is evidence-based practice? This is the APA publication that's being revised, or I think lots of things are being revised and updated. It's worth reading though. It's well written, and even though it's almost 20 years old, there's a lot of great information. This is one of the articles that I recommend about what is evidence-based practice, what is evidence-based assessment. This is the best article, in my humble opinion, on evidence-based psychological assessment specifically. Highly recommend reading that one. Oh, I do love Kandinsky. Be aware of cognitive biases and the fact that we are often, I'll speak for myself, I am often not aware of the cognitive biases I have, which is why it's important to get consultation and feedback and periodically ask oneself and go through systematic procedures to challenge myself, to cross-examine myself even, to make sure that I'm being objective and as unbiased as possible, and sometimes to identify some cognitive biases. I'm moving along quickly to get to the most important. So what evidence-based psychological assessment, I got those letters mixed up a little bit. So I suggest that evidence-based psychological assessment of veteran disability incorporates the scientific method, hypothesis testing, consider both the probability that given A that B. So the probability that a veteran, if they have traumatic stresses, that they have PTSD, but also the probability of people who have PTSD having this kind of traumatic stressor. So this is the kind of thing when you read about Bayes' theorem and Bayesian statistics. This is an important concept. Also, cross-examine yourself, as I mentioned, and your evaluation should be informed by the best psychological science. There's a lot known about base rates of PTSD. When a veteran comes in and says, my drill sergeant, and these are real examples. My drill sergeant was mean to me and yelled at me and called me horrible things, and I developed PTSD as a result. When you talk with most veterans, they're going to laugh. And particularly if the veteran went on to serve for 3 or 4 years in the military, well, why didn't you leave him? It was so horrible. It's there's more complexity to all that, and some veterans have been abused by drill sergeants. So you have to look at the base rates, though. If there's abundant evidence that this drill sergeant was horrible and he was eventually imprisoned, as a result of his behavior. Okay, that's one thing. On the other hand, your average boot camp for most service members is not fun. They get through it, and it's for a purpose, and they're not traumatized. So the base rate is exceedingly low. So you have to consider, okay, this vet says he has PTSD because the boot camp. What's the base rate? It's probably 0.01%. So what are the odds that he's got PTSD? That's the kind of thing to be thinking about with base rate. Clinical judgment's important. Sometimes people think we're talking about evidence-based that it's all actuarial statistics. Not true. I'm only got about 6 minutes left. So the specialty guidelines for forensic psychology are aspirational, and I encourage you to aspire to the highest level of performance as a psychologist, and to, as much as you can, support your evaluations so that they're consistent with the specialty guidelines. So concrete, where's my concrete and steel? My former wife's what's happening? Karen, is there a problem on your end? Oh no, my end. So construct your assessment protocol with concrete evidentiary rules, field ethical standards, and construction best practices, professional guidelines. I'll let you read most of this, but again, federal rules of evidence. These are probably the most important, in my opinion, ethical principles for VA disability exams. And then specialty guidelines that are particularly important. So ask yourself, is my evaluation, my exam consistent with these guidelines and ethical standards and the rules of evidence? And I went over some of this earlier. One of the most important things to do, given the limited time, this is the goal. You're not going to be able to do all these things with most exams these days. And it was true for the VA too, for some medical centers. I think I'm going to stop now to let you all ask some questions.
Yeah, and again, just a friendly reminder to you guys, you have all these slides, so don't worry about having missed something or jotting it down. You have all of the slides in the most recent email I sent you. If you have a burning question, I'm going to let you go ahead and unmute yourself and just ask it. I know we've had some popping up in the chat, but feel free to unmute.
Yeah, I was wondering, how strict have you found the use of the PAI and MMPI? I've conducted a lot of these over the years, and I know they've changed in different roles that I've had. I won't talk a lot here, but specifically, I found right now with VA community care, I got someone coming in with me. Their stories are so clear cut. I mean, I do an assessment and I try to adhere to those standards. But if I sit down and try to set them down to an MMPI or a PAI, one, I don't think it's going to add that much. I think it's going to complement it. And two, hopefully they won't run out the door.
Right. Dave, you gave them MMPI too.
Yeah, right. Well, I don't even want to take that. I wouldn't want to take one of those things. But I was just in some curiosity about that that particular issue.
You're making a great point, Ron. Thank you. I agree with you. If are you in a therapy role or are you doing CMP exams?
Well, I'm doing it from community care, and it will come up as an issue. So I am a therapist. I have had a couple of calls, and I have done it more where that's all I did. That was my total role. But now it has this kind of oddball hybrid. They come up and say, I need someone to add, and it's appropriate for me to say, yeah, your diagnosis fits that because I got to diagnose you that to give you treatment. And they may not have come to me with that diagnosis, but I go, you cannot not be PTSD from my sitting here with you.
So I've got something in the handouts about how to write I think it's on my website. I've done a flurry of writing for my website newsletters recently, so I may be getting it mixed up. I have something written, and feel free to email me on how to write a good so-called nexus letter as a therapist. You can write a good letter that supports your veteran without getting into the multiple role problems, ethical problems the clinical versus forensic distinction. And this is probably what you're doing. You're probably writing an intake and therapy and progress note that you would write anyway, even if the veteran was not applying for disability benefits. You might put a little more detail in there. What I suggest, Dan, when we're in the clinical role, is that particularly since you know what's involved in the adjudication of disability claims for vets for PTSD and other mental disorders, is provide perhaps more detailed description and what they're reporting. That speaks volumes to adjudicators at the Veterans Benefits Administration. They're going to take that seriously, and it will be probative. It will has evidentiary value and weight. You can do all that without giving an expert witness opinion. It can be a problem, and the VA encourages its mental health clinicians to not complete DBQs for veterans, to not give medical opinions if for someone you're treating because of the potential dual role conflict. But you can do a lot that's going to support the veteran's claim that's of a clinical nature. Does that make sense?
Okay.
It may be hard to get the sign back on, so I can go on to the next question.
Yes.
Okay. It is almost time. I just want to do my housekeeping, and then if you do have another question, you're welcome to stay on and ask. Evaluations will be popping into your inbox. I just realized I didn't hit send on them. I'm about to hit send, so give it 5 minutes. They will be popping in just a moment. I'm about to do that. Please make sure you complete the evaluation by the end of the day, Monday, the 22nd. I will send you CE certificates no later than Tuesday, the 23rd. Again, you have all of these slides. You're welcome to contact Dr. Worthen. And if you do have a question, feel free to unmute and ask.
Hi, Mark. It's Sean Atchison.
Hey, Sean.
Hey, Mark. I've got a question about how you as a private provider of C&P exams, how do you handle situations in which symptom validity scales on the TSI or the MMPI or the PAI seem to suggest some dissimulation? Do you just go ahead and write do you go ahead and write the report? Do you give the veteran feedback to say you can't proceed? I mean, how do you generally handle that? I mean, it would be different for an MDE company, but as a private provider, I'm just curious what you do.
No, it's a great question. So I have in my informed consent a paragraph that talks about how it's the norm for veterans to usually, almost always, or at least the majority of the time, subconsciously exaggerate symptoms. And there's a lot of research on this showing, like, for example, MMPI validity scales being highly elevated when veterans have genuine PTSD, when they've done really thorough evaluations. And yeah, they definitely got PTSD, and their F scale is 98. So that's one thing. And I sometimes will give them feedback on their MMPI results, for example, and then ask them if they want to do another instrument that's similar and have them do the PAI. Now, that does break the standardization instruction some. I note that in the report, and I note that it could affect the result. So that's one option, not extremely controversial, but there's some controversy about whether or not psychologists should do that.
Right.
I try to screen really carefully in the beginning. So about 40% of the referrals I do, and I specialize in doing really complex cases, and I do I put like 15 hours into these evaluations and write long reports. But I try to screen about 40% of the vets who contact me. I tell them, no, I don't think, I don't want to take your money to do an evaluation because I can't, it's probably the odds are not great that it'll help.
Right.
So that's another thing. And I think the main thing is keeping in mind that research that shows that veterans with genuine PTSD and other disorders elevate the validity scales a lot, partly because of the demand characteristics of the evaluation. If they're really elevated super high, then I'll administer additional validity tests like the MENT, moral emotional numbing test,
right,
to try to get a sense of what's going, are they really feigning or exaggerating so much that I cannot determine if they have this
Right.
disorder.
Thank you, Mark. Appreciate it.
Thank you, Sean.
Thank you all. You're welcome to stay. If you have another question, you're welcome to unmute as well. If you would, yeah, you're welcome to unmute if you have any other questions.
Would you comment on whether you use the checklists like the SCL or the GAD or the PHQ, and in situations where there's simply in time to use lengthy measures, do you find those short screening instruments helpful?
Great question. Since they are screening instruments, I assume that if they filed a claim for a mental disorder, they either definitely have a mental disorder, and there'll be records, number one, records supporting that. And I'm going to be doing an evaluation. Even if I was doing them for MDE companies, I'm going to be doing a careful interview and reviewing the records, and hopefully doing a collateral interview. So my belief is that I don't need to screen, because I already know they've got a disorder. They could be totally faking it. That actual true malingering, where it's intentional. They want the money. They don't really have a disorder, or they have one disorder, but they're making it seem like it's another one, etc. That is actually not that common. What's more common is significant exaggeration, often subconscious, often innocent, sometimes not, and that's where we have psychological instruments that help to identify that. If you can, I recommend using a broad band measure of psychopathology like the PAI or MPI. It goes back to the principle of multi-method assessment, that we achieve more accurate results if we use different methods and as many different sources as possible to arrive at the truth and what's going on with this person. So if you can, those measures are helpful, as are structured diagnostic interviews, as are specialized instruments like John mentioned, the TSI too. Trauma symptom inventory is really helpful with sexual trauma survivors. So those are some of the instruments that I'd use if I can. Also measures the functional impairment.
Thanks.
Thanks, Susan.
Any more last minutes, Ron? Were you waving or were you?
I just want to say thanks, mate.
Thank you, Ron. I really appreciate that. Nice to hear that from an experienced psychologist who knows this stuff really well. I can tell.
You got me focused and pointed with my vets. Thanks a lot, Ben. I'll let you go.
Thanks.
I guess I have a quick one, Karen, kind
Yeah,
of
go
dovetails
ahead.
on
Sure.
Susan. And so Susan and I are contracted with the same MDE company, and yet I've done forensic work in other contexts. So this may be beyond what a 2-minute question is, but just so we've got 2 hours, and we do get extensive records, but do you have any, I read the slides, but I guess just suggestions for balancing it. Like, we really aren't given time to do a PAI, nor are they going to pay for us to do a PAI. And I feel like a lot of times I can do a good job with a good structured interview and a couple of things, but I guess just balancing it, 4,000 pages of records, a couple of hours, and sometimes I get claims that it's like the veteran said it, but I don't see much backup. Like, I think he really has it. I think they really actually have the condition, but like they've never sought treatment. There's not anyway, just kind
Right.
of
No, that's really that's the
that.
that's the
Like,
$64,000 question, and I'm
right.
dating myself with $64,000 question.
I'll let that go.
Thank you. It's hard. I think that there are a lot of psychologists and psychiatrists who are military veterans who will not do these because they don't feel like they can do an ethical job within 2 hours. So that's one perspective. And then on the other hand, well, this is what the VA will pay for. I mean, the MDE companies are only allowing 2 hours because of how much the VA is paying them. So it's hard. I think that the one aspect to think about is if since you're never going to be or probably never going to be cross-examined, and if your opinions are favorable to the veteran, the odds of being questioned are extremely low. So ask. I think what I do is ask myself, how much am I being influenced by the fact that I know that if my conclusions are not favorable to the veteran's claim, I'm going to hear about it one way or the other. How much of an influence does that have? And I can make more money if I do more evaluations, and I can do more evaluations if I give conclusions that are favorable. So and I know you're aware of that. I think it's, and I think about this being in private practice, and if I'm hired by an attorney or by the veteran, that I'm dealing with the same thing. It's the allegiance bias.
Right.
So it's important for all of us. What the other thing I would encourage you to think about, and all these things I ask myself, and I've been challenged by my friends to ask these questions, is what does the research say about an individual psychologist's ability to, for example, detect deception based on an interview alone? Our hit rate is 54%. So we're able to detect deception only 4% better than flipping a coin. And by the way, it's also true for most law enforcement professionals, judges, etc. There are some exceptions for some really well-trained, exceptional people. Vast majority of human beings, including psychologists, psychiatrists, etc., we cannot detect deception based on an unstructured interview any better than much better than our coin toss. So, thinking about that kind of research, I ask myself, how much confirmation bias is going on? Now, if you've got a veteran who's been in, they suffered through IEDs in Iraq, and they had buddies who were, murdered in front of them, and they report post-traumatic stress disorder. Some of these claims are just open and shut. Yeah, no, you don't need to do the MMPI for something like that. I mean, if there's abundant evidence, and you talk with the wife, and everyone's sobbing, including you. I mean, I can't tell you how many exams I've been crying along with the veteran and his or her spouse, because it's just so horrible what a lot of these guys and gals have been through. So you've been, some of the cases are just so clear, or a veteran's already service connected and they're filing a claim for an increase in their disability rating, and there's all sorts of evidence from buddy statements, collateral interview, reports from the workplace if they still are able to work some, and their treatment, the psychiatry and mental health notes, progress notes. If it's really, really, if there's abundant evidence from different sources, then no, I don't think you have to do a bunch of other testing. It's in those cases where it's not so clear that I think additional assessment can be helpful. That's not a full answer to your question, but am I answering at least to some extent?
Yeah, no, that was really helpful. And just really quickly, what was that listserv you mentioned, or how do you get on?
Yeah, it's on the reading list.
Okay.
Yeah, there's a link to a page. I do ask everyone when they join, when you fill out the little form, it's through Google Groups, is say why you want to join. It's just enough information so that I know that, and there's a couple other people that help with the moderation, just so we know that you are a psychologist and you're doing these exams, website address or your NPI number or something. And then after that, you'll be asked to ask everyone, or we ask everyone, I should say, to sign a promise to keep everything confidential so that we can be more open. We still don't talk about PHI or PAI, et cetera. And there's some caveats in there about we can't keep everything confidential and guarantee it. We do ask everyone to make a commitment though to keep things confidential. And it's run really well for a long time, so I think it's worthwhile.
Thank you.
You're welcome. Thank you. I appreciate that. This is a photo from an article, a little thing I wrote about masculinity. I just adore this picture. So that's it. Thanks so much. Those of you that are alive, thank you very much, and thank you, Karen.
Yeah, you're welcome, and I will be in touch with you, sir, soon.
Great.
Thanks,
Thanks.
everybody. Thank you so much.
Bye-bye.
John, do you happen to be out there since it's just us?